أنا ريم العجلوني مديرة البرنامج الأردني لسرطان الثدي. باسمي وباسم البرنامج برحب فيكم جميعا، سعيدين يعني بانضمامكم لنا بهذه الويبينار إن شاء الله الشيقة أكيد مع الدكتور حكمت عبد الرازق. باسمي وباسمكم بنرحب بضيفنا العزيز الدكتور حكمت عبد الرازق. أهلا وسهلا فيك دكتور حكمت، شكرا لك لانضمامك لنا بهذا المساء. الدكتور حكمت وهو غني عن التعريف، هو المدير الطبي في مركز الحسين للسرطان، وهو نائب المدير العام في مركز الحسين للسرطان. هو استشاري وأستاذ الأمراض الباطنية وأمراض الدم والأورام، ورئيس قسم الأمراض الباطنية والأورام في مركز الحسين للسرطان. هو باحث رئيسي في مركز الحسين وقائم على أبحاث وتجارب سريرية دولية في مجالات سرطان الثدي والأدوية الجديدة، وهو قائد كتابة منهجيات علاج سرطان الثدي، ومؤسس لأكبر برنامج زمالة لطب الأورام على مستوى المنطقة. فدكتور حكمت أهلا وسهلا فيك. موضوع حلقتنا لليوم اللي هو أو موضوع جلستنا رح يكون عن الفحص الجيني لسرطان الثدي، الفرصة الضائعة. رح يكون برزنتيشن من الأستاذ الدكتور حكمت عبد الرازق لمدة 40 دقيقة، ومن ثم رح نفتح باب الأسئلة والأجوبة. بالنسبة للأسئلة والأجوبة بإمكانكم تبعتوا لنا إياها باستخدام فيتشر الQ&A عندكم على الشاشة أو بالشات. وإذا أيضا حدا بحب إنه يسأل السؤال يعني بالصوت والصورة، فلو سمحتوا استخدموا فيتشر ريز هاند، وفريق عمل البرنامج الأردني رح يعطيكم access على يعني to unmute yourself وتسأل السؤال. طبعا هذا في آخر 20 دقيقة. فدكتور حكمت ما بدي أتأخر عليك أكثر، أهلا وسهلا فيك وتفضل.
شكرا ريم، وشاكر جدا لريم ولبرنامج سرطان الثدي على الاستضافة. بسم الله بنبدأ إن شاء الله. التوبيك اليوم زي ما حكت ستريم about the genetic testing in breast cancer. And I will show you how this tend to be a missed opportunity, but luckily enough we managed to grab on it and started doing lots in this regard بعمان بمركز الحسين للسرطان بالتحديد, و hopefully in lots of the other centers in the country very soon. This is my disclaimer, nothing in terms of conflict of interest. We have lots of grants, but this is at institutional level and not really for me in person. I always, when I talk about the genetic testing for breast cancer, I always start with the story of Hollis Seigler. Hollis is an artist, a very famous artist in Chicago. Her story dates back to more than 20 years ago when her grandmother was diagnosed and died of breast cancer. 1983, her mother was also diagnosed with breast cancer. And in 1985, she herself was also diagnosed with breast cancer. So we have a 3-generation, Hollis herself, her mother, and a grandmother. 1992, Hollis, as an artist, started a program of painting على غلاف مجلة Breast Cancer Journal, very famous journal in breast cancer. And the topic and the title of her painting was kind of interesting, and that is Walking with the Ghost of My Grandmother, who was diagnosed and died of breast cancer. These are some of her very famously painting. And if you look at one of those, this is the cover of the Breast Cancer Journal, and this is the title, Walking with the Ghost of My Grandmother. If you see anything, you see a ghost here, you see lots of the empty chairs, okay? You see mirrors, and you see scattered clothes here and there with nobody in there, just to illustrate what she called the ghost of her grandmother. 1993, her cancer had spread to her bones, spine, and pelvis, and 2001, she herself died with breast cancer. So grandmother, mother, and herself died. All three of them died with the breast cancer. With that also, I always talk about the cover of the Newsweek back in 1993. The title of that cover was The Hunt for the Breast Cancer Gene. And that the Newsweek, for that week, they featured the story of a grandmother, Jo Cunningham. She was a 59-year-old. She was diagnosed with breast cancer. Her daughter, Julie, she was 29 years at that time, and she was also diagnosed with breast cancer. And the question raised by the Newsweek back then, will Alexandra, this little girl who was 5 years back then, will be spared the breast cancer? Well, that was in Chicago for the artist, and this is New York for Joe and Julie Cunningham. And I will take you إلى مدينة الزرقاء بالأردن. This is back home. Give you a story, a real story, a patient of ours treated and managed at the KHCC. This is a 44-year-old female patient who was diagnosed in 2015 with left breast cancer outside KHCC. She had a tumor with ERBR positive, HER2 negative disease. She had breast conserving surgery, chemotherapy, and XRT. This is back in 2015. All was done in an institution outside KHCC. A year ago, 2020, she presented to us with a right breast lump. Workup showed that she had another breast cancer on the other side. She's married. She's a 22-year-old. When she was first diagnosed in 2000, at age of 22, she had 5 children. This is her family tree. As you see, this is the patient. The end of discussion. Just a little history. We discovered that her grandmother was diagnosed and she died with breast cancer at age 55. We also noticed that she had 2 sisters, aged 42 and 38, and I will give you her other story at the end of the lecture. So what we did what we call genetic testing on this lady because of the second breast cancer, and it turned to be positive and a gene called BRCA1. So that lady, من الزرقاء, she was diagnosed with positive mutation for a BRCA1 gene. So the question is, had we, and we mean us as a physician, missed the opportunity to save her the second cancer? If we have really done genetic testing back in 2015, we knew that she had the BRCA1 gene mutation. Could we have done something differently to save her the second breast cancer? So this is why I call a missed opportunity, and I'll tell you details about how this missed opportunity can be a real opportunity. Now, why we talk about the BRCA and genetic testing nowadays? Well, we know a lot better. We do understand the prevalence of BRCA mutation in the country, and I'll show you. We understand also the associated risk of contralateral breast cancer, the other side, and other cancers like ovarian cancer. We have also the technology nowadays. We have a technology called next generation sequencing. We now can sequence the DNA in a few hours, and we can do lots of genetically testing and panels. We do 11 genes, 21 genes, 84 genes, and this is really being done almost everywhere nowadays. And we also have lots of new drugs to treat patients with those mutations. So it's not only that we can prevent breast and ovarian cancer. Patients with a mutated the BRCA, for example, can be treated with a new drug called olaparib. So breast cancer that we know that they have the BRCA mutation can be specifically treated with this drug, and this is the difference. In red, okay, this is the outcome of patient treated with olaparib, okay, a PARP inhibitor, and in blue, this is being treated with the regular kind of chemotherapy that we usually give. There's another drug, this is a 42% risk reduction. Another drug, another PARP inhibitor called talazoparib. Talazoparib also, if we treat, this is the talazo in blue, and this is regular chemotherapy in green, and you see there's a difference. Those patients, BRCA positive, treated with talazoparib, do better than chemotherapy. That was in breast cancer. Olaparib again in ovarian cancer. You see the difference is even wider. So if we identify a breast cancer patient or ovarian cancer patient and we treat them with a drug specifically that can tackle this mutation, patient tend to do a lot better. So what is BRCA1 and what is BRCA2? Well, the story gets back to 1990. The place is, this is University of Washington in Seattle. And this is the lady called Mary King. And everybody later would recall her the King. Okay, well, Mary King, and back in 1990, she stated that the cancer developed as a result of a mutation in one of the genes. And those mutations could be a growth factor or an inhibitor of DNA repair and replication. So if you identified those genes, you could theoretically prevent the occurrence of breast and ovarian cancer. And this mutation, they do occur at the germ cells in the ovum of the sperm, which means when the sperm and the ovum unite to form the zygote, okay, this kind of mutation will be inherited from one generation to the other generation. So this is something inherited. So if anybody carry one of those mutations, just because it's carried in the germ line, this is inherited. And the family member would have a 50% chance of carrying this mutation. Now we know that 80% of breast cancer are sporadic, means there's no family history. 20% of those are what we call familial breast cancer. In the past, a very few fraction of those were inherited, but nowadays with expansion of knowledge, DNA and DNA sequencing, we know a lot better, and lots of those genes are inherited. Back in 1994, Mary King was able to identify what we call now breast cancer gene number 1, or BRCA1. And a few years later, a company dealing with lots of those DNA called Myriad, they identified the second gene called BRCA2. So we have now 2 genes, one chromosome 17, this is the BRCA1, and another gene in chromosome 13 called BRCA2. And since then, there's a huge development in inherited breast cancer. And this is the Barack Obama giving the National Medal of Science to Mary King back in 2016, it's covered. Since then, Myriad as a company took the yield, and they start doing what we call MyRisk offering testing, and the usual cost of the test until a few years ago, it usually used to cost $5,000. It dropped down a little to $3,000, so it was expensive and limiting its utilization. Back in 2013, the Supreme Court in Washington, D.C. ruled that human genes cannot be patented, and everybody has the right to do the testing without going to the company Myriad. And since then, the cost of $5,000 went down to less than $500. So now we can sequence BRCA1, BRCA2, and other 80 genes for less than $500. And this is why it's becoming really very popular. So if you look at the size of the problem, as you see here, that at least in Jordan, stopped working. In Jordan, for example, this is the data that everybody knows, that we diagnose close to 12 or 1,300 breast cancer cases annually. And what's interesting, pointer is not working. What's really important is that 20% of those cancers in Jordan and probably in the region are breast cancer. And if you look at the female breast cancer, I would say that the close to 40% or so, it's not working, close to 40% or so of those cancers, breast cancer in female, are breast cancer. So talking again, that the 40% of all cancers in female are breast, which represent the 20% of all cancer load in the country. And if you look, I would say also that 12% of all women will develop invasive breast cancer over the course of their lifetime. So any woman, if she survives until the age of 70s or 80s, the chance that she will develop breast cancer is 12%. 10 to 15% of those females would carry BRCA1 or BRCA2, which is quite huge. And if somebody carry BRCA1 or BRCA2, chances to develop breast cancer is up to 75% of those patients, okay? And chances to develop ovarian cancer goes up to 40 or 50%. So carriers of BRCA1 and BRCA2, chances to develop breast and ovarian cancer is huge. So Based on this, our journey at KHCC back in 2014, we started our genetic breast cancer program. We went to Leeds Cancer Center. We sent a genetic counselor to be trained. And 2015, we started the service at KHCC. We teamed up with MD Anderson back in 2015 with a grant of $200,000 back then, and we published our first result in the country about testing BRCA1 and BRCA2, and we find a huge percentage of patients with BRCA1 and BRCA2. And the last year, this is July of 2020, we published our data on more than 500 Jordanian breast cancer patients, and this is really based on what we call NCCN Guidelines. As you see here, this is the result. If you take, for example, a subgroup of breast cancer, what we call ER negative, BR negative, HER2 negative, or triple negative, chances for those patients to carry BRCA1 or BRCA2 is 35%, 1 in 3. And among the whole population, chances for being a carrier for BRCA1 or BRCA2 is close to 40%. And those with family history, talking about 16.5%. That's huge. Well, back then and until very recently, we at KHCC and everybody was interested enough and looking at BRCA1 and BRCA2. Then as we develop rapidly in this field, there's lots of other genes involved in breast cancer like CHIK2, ATM, PALB2, TP53, etc. So at KHCC since 2019, November 2019, we started testing not only BRCA1 and BRCA2, but we do test for 20 genes, and more recently, we went up to 84 genes in a research setting. So it's not only BRCA1 and BRCA2. And we're looking at it for breast, ovarian cancer. We're looking also for GI malignancies. We're looking for prostate cancer and other inherited cancer syndrome. And our aim is to try to prevent the occurrence of cancer to start with. Well, breast cancer prevention or prophylaxis is not something new. It's been there since at least 1975. So it's been there for more than 50 years. And since then, there's lots of publication about trying to prevent the occurrence of breast cancer based on genetic testing. None of those articles have a major impact, not even in New England, the article, as important as the real impact. People start to talk about the genetic testing, BRCA, when Angela Jolie break her story back then when she stated that she had made a decision to have a preventive double mastectomy based on BRCA testing. And that's then when people start to talk about the BRCA and genetic testing and inherited breast cancer. So her story was much more popular than thousands, if not millions, of the scientific papers published in leading journal like the New England. We'll go back to our patient, Zarqa, and this is the lady who was diagnosed, as we said, in 2015, and we tested her recently, and she was tested positive. Well, according to the science and the publications, this is a paper which was published in 2013. So we know from 2013, according to this paper, what are the chances if we knew in 2015 that this lady, she's a BRCA carrier, what are her chances to have breast cancer on the other breast, what we call contralateral breast? It's 83%. So when she was diagnosed in 2015, if we knew this, if we had the facility and the genetic testing, and she was a BRCA positive, we would know, this is the BRCA, we would know that her chances to develop breast cancer on the other side is 83%. If we knew that, then we would have done something. We would be okay, talk about the patient, talk about her sisters, okay, and do what we call a pre-testing counseling. We will talk to her about what her risk, perceived risk, what is the expectation if she's BRCA positive, why should we do testing, what we call motivation. We have lots of good reason to do the testing. Learn about her risk for children, for example. Lots of decisions in marital and childbearing decisions. but we have to focus also about lots of psychosocial well-being of the patient. Lots of those patients, they had a previous history of cancer, like our patient. Lots of those patients have family loss related to cancer. And some of those patients, they're approaching the age when their loved one had the gut cancer and died of cancer. And we also have lots of risk. So there is benefit of doing the test. There is the potentially some risk. These are confidentiality. We are a close community. كل الأردن كلها 20 30 حمولة. Okay. And people would not disclose that the فلانة من العائلة الفلانية she carry a BRCA1 or a BRCA2. So confidentiality is an issue. Insurance and job discrimination is an issue. Adverse psychosocial reactions is also an issue. There's lots of family stress and that we need to take care of. And more importantly, we need to do some interventions. So we tested the patient. We have to do some intervention for the family, for the patient, and for her two other sisters. So we did test the sisters. And as you see here, this is the 42-year-old sister turned to be positive too. So our patient's positive, and when we tested her sister who's the 42-year-old, completely healthy now. She never had any breast or ovarian cancer. She was tested BRCA positive. And the question is, what to do with those? We have to do what we call a risk-reducing intervention. We have to do what the Angela Jolie did. We have to do double mastectomy. But when we say double mastectomy, in the mind of everybody would go like this lady on the left, will go flat. And that's not true. We no more do bilateral mastectomy this way. We do it in a way, we do a scar or a wound, we take just the mammary glands and we keep the nipple, we keep the breast, and we leave it. Underneath this cover is a photograph of a lady who had what we call skin sparing, nipple sparing mastectomies. Just because the picture looks like a normal breast, I could not display it. Okay, but believe me, we can do bilateral mastectomies, okay, with implants, and nobody but God, patient, and the surgeon would know that she had the double mastectomies. And because of that, we have recently guidelines about the management of those patients. This is came out of the American Society of Clinical Oncology, American Society of Radiation Oncology, and Surgical Oncology. And this is based in big data. And we knew also from studies back in 1999. And this is another study called the BROSA study that double mastectomy works. And this is the study from 2005. This is in green. If we do bilateral mastectomies until 30 years of follow-up, very few of those patients would develop any kind of breast cancer. But if we don't, only 20% or less would remain without the breast cancer. So double mastectomy for those patients, it does work. What about the ovaries? Ovaries is difficult to detect because it's hidden in the pelvis. So nobody would know that the patient is having ovarian cancer. Breast cancer, you can do breast exam, you do mammography, MRI, you detect breast cancer early if you want. But when it comes to ovarian cancer, there's no way of detecting it early enough. So what we do bilateral oophorectomies. But when should we do it? This is an pinkish one, the BRCA1, and as you see here, ovarian cancer start to happen to kick off at age 40 and for BRCA2 at age 45. So we leave females until the age of 40 or 45. We will let them get married, get a pregnancy as much as they want until the age of 40 or 45 when the ovaries start anyhow with no much of a work in there when we do oophorectomy. So if you have to do oophorectomy for those patients, we do it at age 40 or 45 after the lady finished her family. So when we do bilateral salpingo oophorectomy, we have also to deal with lots of the hot flushes. We have to also deal with osteoporosis because we remove the ovaries, but this is manageable. We have to do also to deal with lots of side effects just because we remove the ovaries. So we can do hormonal replacement therapy for a short term until the age of 50. And the question is, what if the lady says, no, I'm not going to go through oophorectomy or mastectomy? In this case, we concentrate on lifestyle changes, reduce the fat intake, increase exercise, weight loss, etc. And we ask the mom to be mom enough. Okay, they have to, as we know, the risk of breast cancer goes down if you do breastfeeding feeding and the early pregnancies. And we have to intensify the screening. We do mammography and MRI to detect breast cancer earlier. We do also what we call a chemo prevention. We offer those lady tamoxifen or one of the aromatase inhibitors if they refuse to do the surgery. However, from our experience, and we did a lot at KHCC over the last 35 years, we never had any issues to convince a lady to do preventive or prophylactic mastectomy. The question next is, are we there? Is this enough? And the answer, probably not. There's lots of issues, you know. The issues is the scientists and researchers, physicians, they think that the guidelines are obstacles. So if you limit the testing to certain group of breast cancer, you probably have an issues. So because we depend on the awareness of physician, it's not really in there lots of times. Family history is not accurate. If you ask a female about her aunts, cousins, lots of them they don't have accurate family history, and also 50% of BRCA positive patients they have no family history of the breast cancer. Okay, and there is lots of times, especially in our societies and even in the Western societies, the communication between family members, cousins, aunts, etc., is not optimal. And there's lots of delays to refer those to a genetic department, that genetic testing. In Jordan, I guess short of KHCC, I'm not aware if there is any properly set up program for genetic testing and counseling. There is a scattered services here and there, but there is no proper comprehensive genetic counseling program. And the guidelines are complex. If you see, these are the guidelines to test for breast cancer. You have to read between the lines and in between the lines, but so those are the guidelines are complex. So what happened? This is the NCCN Guidelines. This is a big study in UK, looked at the adherence of physicians in London for those guidelines. If you look at ovarian cancer, less than 20% adherence. If you look, for example, at breast cancer, less than 40% we have adherence to the guidelines. So the guidelines can be an obstacle. So based on this study, this is a very nice paper, came out just 2 years ago about the fact that if you adhere to the guidelines only, we have tremendous underdiagnosis of hereditary breast cancer. And the study came out from Nashville, Harvard, Mass General, and the Cornell. So it's a big study. In 20 community hospitals, they took the females aged 18 to 90, all patients with breast cancer, regardless. So this is not guidelines. It's each and every breast cancer, regardless of their age or family history or type of breast cancer, all those females were tested for 80 genes, regardless of their guidelines. This is a 1,000 patients were entered, and this is the result. Among all breast cancer tested, chances to find a pathogenic mutation is close to 9%. And in guidelines, it's 9.34%, and those off guidelines are close to 8%. So if we restrict testing just for guidelines, we would have missed those 7.9%. And based on this, the American Society of Breast Surgeons 2 years ago came up with a new recommendation. And the recommendation is genetic testing should be made available to all patients with a personal history of breast cancer. So we don't restrict testing nowadays to breast cancer with high risk or family history. Now, lots of societies, scientific societies, and guidelines call for each and every breast cancer patient need to be tested. We're doing this at KHCC in a research setting, but we have not implemented yet. We do it still on guidelines. And these, the American Society of Surgeons, it's not anything. It's Harvard, it's Mayo Clinic, it's MD Anderson, it's Hopkins, it's Memorial Sloan Kettering, Mount Sinai, etc. So these are the hospitals that implement or start to implement universal testing for breast cancer. But we still have an extra mile. We're not there yet. I'll take you to this thing, and this is a study came from Mayo Clinic. They are not restricting their testing for breast cancer. They're testing each and every cancer patient. And a study, they called it the Intercept. So the Intercept, or the Interception study, this is a big study, okay, between April 2018 and 2020. They tested all kind of cancer, regardless of their age, family history, ethnicity, etc., and they test them for 84 genes. And this is the cancer tested: breast, GI, endocrine, GI, GU, skin, etc. You call it. And these are the 80 genes they tested. And these are the results. The 3,000 patients were entered, and chances to find pathogenic mutation if you do 84 genes is 13%. Which means if you just walk into any hospital with the cancer and you do genetic testing for those patients, 13% would have a genetic testing in both the patient and their family members. So 6.9 on guidelines and another 6.4 off guidelines. So, and this is the result of the testing in a breast, colorectal, pancreas, you call it. Two conclusions out of the study. First, about 1 in 8 patients with cancer will have an inherited genetic mutation. Inherited means there's a family member at risk. That's number one. So 1 in 8 patient, that nearly half of these mutations would have been missed if we use just the practice guidelines that we have. But if you extend it, you will double that. Not even that, we still have one more to surprise you with, and that is, this is the King. Okay, this is the same lady, Mary Claire King, who discovered back in 1990 and 1994 BRCA1 and BRCA2. What she stated last year during San Antonio Breast Cancer Symposium, very surprising. She's calling that all women, regardless whether they have cancer or not, at age 30, they should be tested for BRCA1 and BRCA2. So a birth, a kind of a surprise, kind of a gift or something for a female when she reaches the age of 30 is to give her a coupon to test for BRCA1 and BRCA2 when she reaches the age 30, because of the high risk of harboring a gene that can predispose her to a breast cancer. Obviously, there are two questions that can arise. Number one, what is the noise that results from testing? Some of those genes are not pathogenic, okay? And this is up to 50% of the patient. What about an anxiety of the patient, her family member? What about the feeling of others? What about the other invasive procedures? And what should we report to other patients, family members, and others? So this has been still a call. It's not implemented. I don't see it happening very soon, but this is something coming. Okay, very soon you will hear that the people will start asking the females at age 30 to do the testing regardless. Is this cost effective? And the answer is yes. These are lots of studies stated that the testing for all breast cancer patients is cost effective. And this is another study. If you do it for female at age 30, if you do it in societies, okay, like the US, UK, Netherlands, it's very cost effective. It can be cost effective in Brazil, but in India, mammogram is not even cost effective. So it's not going to be cost effective there. So is it really cost effective to do genetic testing for each and every female at age 30? Okay. In countries like the US, UK, Netherlands, the answer is yes. In our country, we're still calculating. We'll see if this is really cost effective. Local data, we have started to look back, what we call a trace back. We're going back to 2006, each and every female diagnosed since 2006, and she fulfilled the criteria. We're testing her for a BRCA, a study we call trace back and uptake. We're doing this. We're also doing universal testing for all cancer patients in a research setting. So each and every newcomer to KHCC now, regardless of their cancer type, whether GI, GU, gynae, breast, head and neck, whatever, we test them, genetic testing with 84 genes in a grant that we get it. And we also doing what we call establishing a clinical cancer genetic program that the focus of this program is the patient, the family, and the community. And this is the component of this program. We do the testing, we do counseling, we do the guidelines, we do intervention, and we do also research. And these are the stakeholders: oncologist, genetist, surgeon, gastroenterologist, etc. So big team at KHCC started this virtually, but hopefully very soon we have the physical place. The aim is this lady try to prevent the occurrence of the second cancer. Our second aim is to prevent the occurrence of breast cancer and other cancer on the sister, which she luckily had not had any cancer so far. These are some of our recent publications. We just published a paper about BRCA1 and BRCA2 in young breast cancer patients below the age of 40. And we also published recently our experience at KHCC on patient with triple negative disease. This is our team at KHCC. And recently also I wrote a review paper describing what I just showed you in a title, Expanding the Search for Germline Pathogenic Variant for Breast Cancer. How far should we go and how high should we jump? And I talked about this mystery opportunity. And the aim is to have the team play in order to have a touchdown and in order to convert what we call a missed opportunity into an opportunity. My 40 minutes is over. I'm done. And please let me know if you have any question.
شكرا جزيلا لك دكتور حكمت. شكرا يعني لك لتسليطك الضوء على هذا الموضوع، على موضوع الجينيتك تيستينج. يعني as you mentioned, the genetic testing كمان يعني it emerged as invaluable tool for early detection. Always احنا at Jordan Breast Cancer Program we are concerned with breast cancer early detection as a cornerstone for improved health outcomes related to breast cancer. دائما بنحكي الكانسر كنترول بشكل عام هو مسؤولية عامة، مسؤولية لكل حدا. يعني في كل حدا بيقدر يلعب دوره، وكل حدا من دوره، وكل حدا من البوزيشن اللي هو فيه. فشكرا لتسليطك الضوء على هذا الموضوع، واللي بنتمنى انه يكون براكتس حقيقي يطبق، وانه المجتمع الطبي بشكل عام يبلش ينتبه له اكثر ويحطه اكثر كبريوريتي وكاولويه للبراكتس وللريسيرش. لكل البارتيسيبنتس معنا، إذا بتحبوا تسألوا أي سؤال بإمكانكم تبعتوه زي ما حكينا على ال Q&A، بإمكانكم تبعتوه على الشات، بإمكانكم to raise hand to open your mic. يعني our team will send you will send you يعني an access to have your mic.
We have some questions على الشات. questions من رولا. Rola Tamimi, she asked, do we have genetic counselor in Jordan? The answer is yes. We have at KHCC 3 genetically counselor trained. One of them was trained at Leeds Cancer Center in Leeds, UK. Does people seek the service? The answer is yes. We so far have done genetic testing in more than 2,003 patients with breast cancer. Just breast cancer, we have more than 2,000. We have done hundreds in GI, ovarian, pancreatic, and the prostate cancer. What is the survival rate after checking their genetic predisposition? This is a controversial. If you detect it early enough, the patient with the BRCA positive, they may have a better survival than the other breast cancer. Is it measured through the SEERS database? No, the SEERS database is very kind of mixed. So we compare our data with the with partners like MD Anderson, UK, and SEERS database is not unified. It's very heterogeneous. سؤال من Karen, what support is available to patients with the mutation at KHCC? We have a huge psychosocial program. We sometimes ask our psychologists and psychiatrists deal with those patients. However, all of us, the breast oncologists, can deal with this. We have enough experience to talk to the patient. So far, we had no major issues with any of those carriers. سؤال من attendee. Thank you, Dr. Hikmat. My elder brother was diagnosed by Hodgkin lymphoma and passed away 25 years ago. Should I do genetic testing, and what is the cost? The answer is no. Patients with Hodgkin and non-Hodgkin lymphomas are not at risk per se for genetic testing in a clinical setup. However, we do have a research, we can do it in a research setting. So clinically, we don't need to. If you have an interest in being part of the research, we can do it in a research setting. These are the 3 questions that I have on the chat. There is another question from Zaydoun. Thank you. My question is, does genetic testing help patients herself from future cancer? The answer is yes. I showed you data based on a study. The risk of having breast cancer on the other side, what we call contralateral breast cancer, is 83%. So if we identify a patient, and for example, breast cancer in one of the breasts, and she's a carrier, okay, chances in she will develop breast cancer on the other side is 83%. So we do prophylactic mastectomy. And chances that she will have an ovarian cancer is 44%. So when she finishes her family, reach the age of 40 or 45, we do also oophorectomy. That's the benefit in prevention. There's another benefit with treatment. الناس الستات اللي بيكونوا عندهم BRCA positive breast cancer, we can treat them with the new drugs called PARP inhibitor. I showed you a difference with olaparib, okay, and talazoparib. These are 2 new oral drugs, حبوب. بياخدهم المريض. They are a lot better than chemotherapy for this subset of patients. هدول هم الأسئلة اللي على الشات. Any other questions, Ria?
ما في دكتور. أي سؤال تاني؟ أي سؤال تاني حدا بحب يسأل؟ If you have any other questions, as I mentioned, you can raise hand or you send it to us over Q&A. Doctor, there is a new question from an attendee. I need to know your opinion about HPV vaccination and prevention of cervical cancer, and does it have a role in breast cancer prevention as well?
السؤال بس للأذرز, بس just to illustrate, this is about the HPV, the human papilloma virus, the vaccination and the prevention of cervix. We published as KHCC what we call a white paper, وحتى جزء منه published بالصحة المحلية. Obviously احنا بالأردن بنشخص من 40 إلى 45 حالة لسرطان عنق رحم أو cervix. Well, this is, as you know, this is related بالعادة, at least in the Western societies, with HPV. Our society is a very kind of conservative. Chances to have extramarital or early kind of relationship at the age below 20 or so among our younger girls is not the same as the West. So the HPV vaccination is not cost effective. Our opinion at KHCC is not to do it. However, I know at least that it's becoming part of the prestige in some families to vaccinate their girls at an earlier age, but the clinical recommendation is not to. It's the value. There's no value in vaccinating everybody with HPV to prevent the 40 أو 45 حالة CA cervix. To answer the questions, إلها علاقة بالCA breast? The answer is no. ما في علاقة بين HPV and breast cancer.
Okay. إذا ما في أي أسئلة تانية فدكتور حكمت شكرا جزيلا لك، يعطيك ألف عافية، وشكرا جزيلا لكل الأطباء والدكاترة اللي انضموا لنا، ويعني مساءكم سعيد، وإن شاء الله أنه بكون لنا لقاءات أخرى ويعني محاضرات أخرى مع الدكتور حكمت ومع أخصائيين ودكاترة آخرين، ويعطيكم ألف عافية. إذا في أي كومنت أي اقتراح بإمكانكم دائما تتواصلوا معنا على البرنامج على إيميل info@jbcp.jo. كمان إذا أي حدا بيحب إنه يكون في عنده certificate of attendance يبعث لنا على info@jvcp.jo، محطوط الإيميل بالchat. دكتور I think في كمان وصل كم من سؤال. Yes, you have 2 new questions.
Can I ask another question? Is there any relationship between COVID-19 and cancer? So far, we don't, luckily, but you never know. But so far, there's no association between COVID-19 and cancer. السؤال اللي قبله من دلال كان genetic testing save women in what stage? I'm not sure if I understand the question right. Genetic testing للي عندها breast cancer, it can save her other breast and it can save her ovarian cancer. And for her sisters, aunts, cousins, it can save them from having cancer to start with. فاللي ما عنده cancer, we do genetic testing, we do prophylactic mastectomies بالطريقة اللي حكيناها مش flat. That will prevent the occurrence of breast cancer. If we do oophorectomy at age 45. At age 45 لا في حمل ولا في pregnancies ولا في شيء. وما في cancer. يعني usually ovarian cancer does not happen below the age of 45 like BRCA carriers. Yes, it can save the breast cancer at all stages if this is the question. The other questions?
Yes, Doctor. في عندنا question. Someone wants to join. يعني ask the question verbally.
Okay.
Yeah.
Go ahead, please.
تفضلي دكتور. تفضلي دكتورة.
She's mute. I think this is Yasar. If I'm not mistaken, you're mute, Yasar.
Okay. Now, can you hear me?
Yes, please, Yasar.
So, Dr. Hikmat, would you recommend that the clients that we see in the early detection unit who have family history in their sisters or mothers, that we do for them BRCA1, BRCA2 testing?
We do for the patient. And just because of complexity of family situation, we currently we do for the patient herself. But for somebody who does not have a cancer, without a family history, we don't do for the complexity of family situation. So if that lady she comes in على early detection clinic عند يسار أو ابتهال وعندها family member with cancer, we go for the family member. If the family member is negative, there's no point of doing testing for any of the family members. If the family member who has a cancer is positive, chances for her close family member first degree is 50% of having genetic mutation with 25% for the second generation. We go after the patient.
Okay, thank you very much. Thank you, doctor. Thank you.
Yes, sir. تسلم.
اوكي دكتور، ما في اي اسئله ثانيه. شكرا جزيلا لك وشكرا جزيلا لكل الحضور، يعطيكم الف عافيه. شرفتنا.
شكرا دريم وشكرا للبريست كانسر بروجرام. Thank you all. I really appreciate the opportunity to spread some light on this. I consider it very important issue at KHCC and the country at large. Thank you so much.
أكيد، يعطيك العافية. شكرا.
يعطيك ويبارك فيك. Thank you.